Hi, good morning, everyone. Welcome to the session on sleep bruxism. I'd like to thank IDA Malabar and my friends Dr. Pravish and Dr. Rooney for helping me spread the word of the actual causes of bruxism, which most of us are unaware of. So I always take it as my privilege to go around talking about the subject, and in spite of us struggling through this corona scare, we are still learning, which is an amazing thing. So can I start, Unni, Pravish?
Yes, sir. You're loud and clear.
Okay, great. So
as of now, we have 127 people who have joined in. We have more attendees to join, but I think this time we can start, sir.
You want me to wait for another 5 minutes? I'm okay. I've got nothing much to do. So
it's being recorded, and those who have missed some part of it can get it in YouTube later on.
Okay, great. Okay, cool. Okay. Yeah. So talking about sleep bruxism, I've been into sleep medicine for the past 10 years now. I did my sleep residency at the Tufts University in Boston, US. So the reason why I had to get into it was because after my training in pain, craniofacial pain, I had a lot of patients coming back, almost 20% of them coming back with pain because they were still clenching and grinding. And unlike what we've been taught, which is 90% of all our clenching and grinding or bruxism is a stress disorder. Unlike that thought, it was kind of a revelation to me when I got to know that it's more to do with the airway and how we dentists can actually help clenching and bruxing with other than just a mouth guard. So that's what we all give, a night guard, right? So I'd like to start my presentation with that regard. Okay. So bruxism, as we know it, there are several definitions: forcible clenching, grinding of teeth, parafunctional grinding of teeth, in sleep or while awake, involuntary rhythmic, spasmodic, non-functional grinding, gnashing, clenching of teeth, leading to occlusive trauma, diurnal, nocturnal. So there are lots of definitions out there, leading to periodontal tissue lesions, sleep-related movement disorder characterized by grinding, clenching. So these are all the definitions that we've been brainwashed into thinking during our dental school days. I'm not suggesting they're all wrong, but what I want to say is it's only 10% of it is true. The remaining 90% is airway. It's all airway. And that's what I'm going to be talking about the whole time today. So it's very difficult for me to, you have to understand, it's very difficult for me to, compress the whole lecture into just 1 hour. I've tried my best to make it as simple as possible with maximum research as possible. If you have any, I'm always a guy who likes to be interactive. So if you have any doubts, you can post it on the Q&A section, and the moderators would pump it out to me. You can interrupt me at any time you want to. It's okay by me. I actually encourage that more than anything else. Okay, so getting on. And these are the mechanisms that we have learned. There are neurological factors, there are stimuli, there is psychogenic elements, which is more than anything else that we've learned about. Medications, toxicity, alcohol, smoking. Daytime wake bruxism is more of a stressful thing. Absolutely, there's no doubt. I'm not refuting that whatsoever. Daytime wake bruxism or clenching is a psychosocial disorder more than anything else. People have also confused between bruxing and clenching. So when a patient comes to you and you ask them, do you brux or do you clench? So more often than not, they say they don't because you don't hear noises, right? But, you know, they could either be grinding or they could just be clenching. Clenching noises are hardly heard. So you need to be more, what do you say, inquisitive to understand. And our diagnosis needs to be a little more precise. We'll get to that part anyway. But the most important thing are oxygen desaturation events, especially during your sleep. So what is an oxygen desaturation? We'll get to that when we get to sleep apnea. So why did I get into treating OSA? OSA is obstructive sleep apnea per se. So like I said earlier, when I started practice, it used to be, 20% of the patients coming back with pain. So when I got to know that clenching was still causing concern, I went abroad. I went and got myself educated in sleep apnea, and then 15% got happy. Again, 5% were having a problem. They were having because of neck issues. So I went forward and learned under Rocabado and got to know got in touch with chiropractors and helping patients with that as well. So it's always a learning curve. You're always trying to learn. You learn new things, try to incorporate into your protocols and help your patients better. By the way, I am, before I forgot to say that, I know I've been introduced, but got to say this. My practice is 100% CMD, craniomandibular disorders, craniocervical mandibular disorders. I don't call it TMD anymore. I'll get to that point again. And sleep, as well as sports dentistry. So all I look at is pain and sleep. So am I actually treating only just OSA, right? So hardly, because you're a dentist, and especially with me, I'm just doing pain. Out of 100 patients, maybe just 4 or 5 come to me with a snoring issue or a sleep breathing disorder. So not many patients, I mean, that's a situation in India at least. So people aren't aware enough to be coming to a dentist to get their sleep disorders treated. So since most of my patients are coming to me with pain, the remaining 95%, as part of our diagnostic protocols, we do sleep studies and we check other things, and which we will discuss in due time. We get to know that they have a sleep disorder, and most of them are clenching and bruxing. And that's when even the patient gets to know. So it's because sleep apnea and sleep disorder breathing is not such a hot topic in medical circles in India even now. So it's just getting there. And I really truly believe that we dentists need to be up there, to help these patients. So from a pain specialist purview, is oxygen desaturation more important? Absolutely. We'll be talking about a sleep study and about how we get to know whether the patient is actually clenching or not. Oxygen desaturations, there are research papers that prove they are directly related to, one oxygen desaturation is directly related to bruxing cycle. I'll show you the physiology behind that. Flow limitations, again, anytime there is a flow limitation in the airway, these are just terms I'm getting you, getting you aware of so that you don't have a problem in the future. So flow limitation is when air is not going enough, but it doesn't reach a stop breathing episode. So that will also cause hypoxia. So both of these finally lead to hypoxias where there's not enough oxygen in your body, and hence bruxism. Really, this is what you're going to know today. It's not just a psychological problem. So all we've learned our lives, sleep bruxism. Is it just a parafunctional habit? Our first response, when you see a patient with totally arthrited teeth, woohoo, full mouth rehabilitation, 28 units, ceramic, full mouth, wow. And you give them a night guard, right? You have to understand that we have to get to the cause of all that attrition in the first place. Why? Why did all those teeth get arthrited in the first place? You would say bruxing and grinding. Okay. So you do your entire work, the rehab, and you give the patient a night guard. That night guard is actually only just protecting your teeth or your work from further deterioration. It's not stopping the sleep apnea per se. The patient will continue to brux. Why? Because 90% of those cases are bruxing because of an oxygen desaturation event. Remember, so if you see this money coming in now, you better make sure that a night guard isn't enough after the rehab. You gave him a sleep appliance. And that too, not at any bite. I'll get to that as well. Okay, so is bruxism just a psychosocial disorder? I guess not. Not guess not, I believe not. Not just believe not, I know not. And by the end of the session, I hope you guys would know that too. So could bruxism be actually a physiological response to keep the person alive? Yes. Does sleep bruxism have anything to do with TMD or CMD? Now patients come up with pain, and the first thing facial pain or headaches or something, and the first thing we say is, oh, the patient has TMD. I mean, we are not taught how to diagnose TMDs, how to help these patients. Max, we would refer them to a radiologist or a surgeon who would give injections or arthrocentesis or some sort of a invasive process, when actually it would just be an occlusion. Since the subject of pain doesn't fall into the gamut of today's lecture, I'm not going to go deep into it, but what I would like to stress is most of my patients that I see now, I believe their TMJs are perfectly fine, okay? But they have an occlusal disorder that is leading to muscle tensions, leading to pain on all over the head, not just the orofacial part, including the cranium, including the cervical area. So we need to know more about the muscles. And this is why when we are in dental school, we are taught about the anatomy. We always wondered, why the hell are we taught, about muscles of the neck and physiology, which we are not even involved in. So this is the reason, because you need to know. Unfortunately, first year, we write the exam. I tell this at all my lectures. We write the exam, we pass, we forget it. Second year, the same thing. Third year, the same thing. It's only the final year subjects that we keep in our mind for the rest of our lives. And we become such tooth-centric doctors that we forget everything else that's surrounding it. And that's how we end up with CMD. I wouldn't say TMD again, CMD, okay? Again, because it doesn't fall in today's gamut, so I'm going across. Do oxygen desaturations during sleep leading to obstructive sleep apnea have any relation to sleep bruxism? So that's what we're going to talk about today. So what is sleep? The anagram says stress, level, elimination, exercise, plan. So again, that is because of our brainwashing during our dental school days, citing the example of stress, the cause of stress. So I'd like to get into sleep. So are these guys really stressed? I always show these photographs. We have a bunch of our elected representatives. They're all stressed out, maybe, from partying too much late night. We have an example just next to it. So not much is happening at our parliamentary houses. So we even have our ex-prime minister sleeping in front of the Malaysian prime minister. We have our favorite Raga, who's doing the same thing. I'm apolitical, by the way, so please don't start a grudge against me for this. It's very scary out there in India right now. So, Dr. Nathaniel Kleitman, he's been deemed as the pioneer of sleep medicine. But I'd like you to remember Christian Gilmanon. He actually just passed away last year. I had the fortune of hearing him lecture while at Harvard. Amazing guy. Almost every paper, scientific research article out there, every paper out of 3 would have his name on it. So he's an amazing guy. He did a lot for dental sleep medicine. So what is obstructive sleep apnea? There are a variety of obstructions that can cause sleep apnea. It's in the term itself, obstructive sleep apnea. So something is causing an obstruction in your airway during sleep that leads to an apneic event. Now, what's an apnea? So you have an apnea, you have a hypopnea, and you have oxygen desaturation. These are the 3 things I would normally concentrate on while checking a patient with sleep apnea or with bruxism per se. But first, let me talk about sleep apnea. So an apnea is where a patient can't breathe for more than, just as an example, for more than around 20 to 30 seconds. And hypopnea is where between 15 to 20 seconds. A desaturation is when, because of the blockage in the airway, there's not enough oxygen getting into your body, and hence the oxygen limit, the oxygen level within your body goes down below 97 or 95%. So every time that event happens, there is a clench. We'll show you why. So this is what more often than not causes a sleep apnea event, a constricted airway. We go through a detailed diagnostic protocol. I'll show you that as well. So this is when the patient is standing up. Imagine this, a patient standing up has such a thin airway, narrow airway. When this is the base of the tongue, it's supposed to be at least here. This area would be around 10 to 15 millimeters square and in area, circumferential area. It's supposed to be at least 150. So when this patient is standing up and awake, if it's only 20, if he's going to lie down because of gravity and neck fat and a lot of other stuff, that airway is going to get compressed even more. Okay, and we have a video that would show exactly what's happening. So you can see how you can see how the oxygen is getting in through the airway here. And if there is a posteriorly placed mandible, like in class 2 cases, or if there's a big tongue, what happens is, since the tongue is attached to the genial tubercles, the tongue falls back when the mandible falls back, and there's an airway block. Now, this airway block would lead to lack of oxygen in the body, as well as an increase of carbon dioxide, because if the airway block is there, the carbon dioxide also doesn't go out. And you should also remember that the heart is now pumping faster because it needs to get every millimeter cubed of oxygen possible to spread across the body so that cell repair happens. And again, there is heart muscle, developing, getting hypertrophic, cardiomegaly. 10, 15 years of chronic sleep apnea, snoring would lead to cardiac attacks. So these are all scary things. People dying, healthy people dying while exercising actually. who are very lean and thin, marathon runners. I've had a friend, that's I'm being very specific here. He used to snore, so never knew about it, never took it seriously. We in India or even in Asia, we don't take snoring seriously. On the contrary, we take it as a joke. So we need to be aware of all of this. And because the heart is getting tired, you also feel a lot of palpitations and dyspnea when trying to do something tough like climbing stairs or doing hard work. So all these are common symptoms in a sleep apnea patient. And whenever this happens, this block happens, and because of the desaturation event, basically the hypothalamus, the awakening center, recognizes this. It tells the tongue, go forward. As it goes forward, it pulls the jaw along with it, and the patient clenches. Now, these clenching forces are really, really huge. As an example, when I talk to patients, when we normally throw a ball, we exert like 75 to 80 microvolts of muscle force. When we chew food, it's around 150 to 200. When we clench in the daytime, it's around 250 to 300. But when you grind at night, those forces are almost 750 to 800, almost 3 to 4 times. And we have proof of this. And we actually record these. So I'll show you how these are involved. And think about it, at these huge muscle forces, what would happen? The first thing that would get destroyed are the teeth, right? At these high forces, the teeth are the strongest, the enamel is the strongest material in the body. At such high forces, it's natural that the enamel would start wearing away, not just from the occlusal side, but also from the cement-enamel junction. Why? Because that's where the enamel is the thinnest. So you see a lot of abfractions, and they are not toothbrush abrasions. I've still heard patients telling a doctor told them it is toothbrush. No, they are mainly caused due to clenching at night. Do a sleep study for those patients. Even if you do a filling on those, you would see after 2 years those fillings coming off. It's not because of toothbrushes, because they're continuing to clench and grind. Remember, those patients they're not going to be helped at all with a mouth guard. They need a sleep appliance. Okay. So 60% of all deaths during sleep are MI related, and 80% of all those MI are caused due to untreated and undiagnosed OSA. So think about how important our jobs are, okay, as a dentist in treating sleep apnea. So when I came back to India around 10 years ago, there was no guiding lights because no one doing this. So I had to come up with a protocol, and our centers known as the Right Bite. So we have 3 centers, and I'm a consultant of the other 2 centers. So I use the same protocols wherever I work. These protocols, they keep adding on because you keep learning new things. For example, the usual stuff, the questionnaire, radiology, TMJ muscle palpation, the cervical rotation, cranial nerve screening, the heart rate voltage, the capnography, they're all new things that I've added in because you keep learning new stuff. But every time I do help a patient with sleep apnea or bruxing, they have to undergo a sleep study and an ENT consult, because as we saw in the first slide, it's not just the tongue. There are other blockages like the adenoids or the tonsils or other lymphoid tissues, which we will see in due time. So these are the diagnostic protocols for sleep per se: radiology and airway volumetry, stop bang questionnaire, the clinical diagnosis, postural exam, and sleep study. So radiology. First thing, the most basic thing, right? Lateral cephalogram. Because some places, when I started out in the beginning, not all areas have the fortune to work with a full volume CBCT unit. So you need to make do as well. So you can see how the airway is patent here. There's enough space. But here, there are multiple occlusions. So this patient is bound to have sleep apnea issues more than them. Just as an example, you can see also the lymphoid tissue formation here, which is basically adenoid. these formations here. OPG, we are looking for, sometimes we do see these carotid artery thickenings, very rarely. Again, they are a signal for cardiac problems. But more often than not, I'm looking at these mesenteric notches, how deep they are. Why are they deep? Form follows function. If a patient continues to clench, there is going to be the masseter pull. And as these pulls increase, you would see a change in shape of the posterior border of the mandible. So, I mean, on the lower border of the mandible. And that notch becomes deeper and deeper. It's all common sense. And my favorite, airway volumetry. So we are looking at the airway volume. Anything that comes in the red zone, which is less than 150 millimeters squared, is dangerous. Some people go for airway volume, but I would prefer to look at the narrowest area of space, because that would be more dangerous to the patient, because this is when the patient is awake and standing up. If the patient lies down, is going to be enormous. That place is going to get closed anyway, in spite of whatever the volume is, right? So I go by the minimum area. So you can see how this patient is having, what's the minimum area? 70 millimeters square. And this is post-treatment, non-surgical, just with a DNA appliance. One of the appliances that we use, it has almost more than doubled. So amazing appliances. We have all these appliances coming into India right now. We have, again, superimposition. This is a patient, the inner circle you can see is 354. And once the patient wore a sleep appliance, which is the outer circle, it's almost doubled. So you can superimpose. So those are the radiology that we depend on. And now we go for the stop bang questionnaire. The stop bang is actually snoring, tired, excessive daytime sleepiness. So some people say they're always sleeping. It's not good. The reason why they're always sleeping is because they're not getting quality sleep during the night. So sleep is divided into normal and deep, which is NREM and REM sleep. So at least 25% of your total sleep should be REM sleep, okay, deep sleep. If not, if you have these oxygen desaturations, if you have these apneic events, you keep your sleep, so you're in normal sleep, you're trying to go into deep sleep, whoa, desaturation. So you're awake again. You don't wake up per se, but maybe you would have tossed and turned around, or you would have kicked, or you would have moved your legs, or you would have, just clenched, for example. So every time that happens, your sleep is getting broken. And that is going to show in your working work quality the next day. So as this goes on and on and on, you get more and more mentally deluded, because it is going to affect your work lifestyle. So oft awakenings, blood pressure is going to be varying. More often than not, it's going to be less than normal. You have the exertional dyspnea, then higher the BMI, higher the age, bigger the neck circumference. So we do ask these patients to go on a diet. We give them a diet actually to make sure they bring down their weight. A BMI should be less than 27 at least. Gender, they say male, but I've seen more female patients than male patients, maybe because in India, I sound harsh, but we'd be more number of male chauvinistic pigs. So we don't fall sick. So more than anything else. Anyway, then we have postural examination. We're looking at facial asymmetry. We're looking at whether right side or left side. Suppose the clenching is more on the right side, then you'd see a thicker right side muscle, asymmetry on that side. Facial rotation, how the face is rotated, going with the bending, eye line, going with the bending. DNS is what you look at the nose. We'll get to that part. We're looking at the shoulder droop, because if there's a change here, to accommodate that, to compensate for that, the shoulder is going to droop, the hip would change position, the feet would change position, and we look at all of that. And correct as well. So if you're looking at airway and posture, I don't know if you've noticed, you'd see people with a forward head posture. The two main reasons are, one, the digital media that we use, the computer or the mobile, the cell phones, as they call in the US. So the head posture slowly comes forward, but there's a huge population that ends up, because the airway is small, the body itself is asking the head to move forward so that the airway opens up. As you can see in this figure, the body is actually virtually telling the jaw to go forward and the head to go forward so that the airway opens up. And you have this kind of a face for most of these patients, mouth breathers, kids who have tonsils and adenoids. When we get to that, I'll explain that. Very famous guy out there. Most of these famous guys, they maybe under the influence, they all have a forward head posture. They consider it cool, the way they stoop and drag their feet when they walk. None of them are erect. It's because of airway issue. So every inch of that head being forward, it's almost 20 kilos in weight. It's a relative number, it's not actually weighing. So that amount of weight would naturally end up with cervical rotations, that much pressure on the neck, and you'd end up with more neck pains and muscle issues. Again, how a baby, there's an airway compression, and how we use our hand or towels to flex the neck so that the airway space increases. And most of these kids, they are clenching and bruxing. So we also use a posture grid. It's a mobile application or cell phone application that we have. It's free actually. So we do all of these on our patients. Once we give the orthotic and the sleep appliance, if the patient still doesn't recover properly, we send them to a chiropractor. We don't have any NUCA chiropractors in India, unfortunately, but we do have a couple of chiropractors in Bangalore, wherever we work at least, in Bangalore, Mumbai, and Delhi. But since they're not in-house, I try to incorporate Dr. Mariana Roccabado's distraction techniques. All of these are taught at our courses, so if you're seriously interested, please join in. We do cranial nerve screening to shoot before we shoot bites, before we treat the patient. We go look at oral tissues and everything. And I don't know how many of you have noticed, there would be a turned uvula. Okay, it could be the right, it could be the left. Something new that I've learned. If the uvula is not in position, that means the uvula is a diagnostic tool to locate to identify how the cranial nerve 10, which is the vagus, functioning. All we need to do is get that vagus functioning again before you shoot the bite. Believe it or not, it's just using a long QT and tickle the uvula. In 2 to 3 weeks, that vagus is functioning properly. So we'll be talking about how the vagus functions as well. Oh God, I'm really slow. Whoopsie, I've got to speed up. So we have clinical examination. The first thing we look at is the Malampati classification. Malampati is an Indian doctor from Andhra. He's a Telugu. Dr. Friedman joined along with him, and they classified the oral space into 1, 2, 3, 4 Malampati classification. So if it's 3 and 4, where you can't see the uvula at all the tonsils, but mainly the uvula, then that patient is bound to have a desaturation event because there's not enough oxygen going in. As an example, you can see how this patient's airway is totally compressed. Why? One of the major reasons that I've seen in some of these patients are faulty orthodontics or prosthodontics, where the bite has been not properly maintained. So this patient has undergone an orthodontic process wherein 4 premolars are extracted to make the smile look good. Unfortunately, they've also been given they had also been given a fixed retention to maintain the smile. So the whole process of the whole idea of giving a fixed retention is so that the smile doesn't get bad again. But unfortunately, there are other structures that are getting compensated and compromised for. and that patient ends up with pain. So you need to be very aware. So take care of the airway issue before you get into finishing the case orthodontically. So we had to remove the fixed retention, the first thing. So you can see the lateral scallop tongue. So since the space is reduced, the tongue is wanting to go forward, but it just doesn't. So the tongue keeps pushing, and these are actually the impressions of the teeth falling on the tongue. You see a Malampati 4, 5, 6. You hardly see the airway out there. You can see the bicuspid drop off because this patient has ended up as a deep bite after orthodontic. So, and ab fraction. So these are the toothbrush aberrations that most of these doctors are prescribing to. So I would say no, please don't say that. These, if you see these, then please do a sleep study and confirm for sleep apnea related bruxism. Lingual frenum, so again, a high lingual attachment or a high labial attachment again would lead to faulty tongue posturing, high palate formations. If the palate is high, I think, yeah, so adenoid and tonsils, well, let me, yeah, 1 second, yeah, okay. We'll get back to the lingual tie a little later. So every time I send a patient to an ENT, I need clearance for the tonsils because they all need to go. We as parents and even our colleagues, our ENT colleagues, are always pretty wary to get those tonsils off to undergo a surgical procedure. But if it is required, yes, it has to be removed. Don't expect it to just regress on its own. If the patient is suffering, they have to be removed. All our ENTs think in those terms, so our patients are pretty much escaping from all those problems. But because you're in touch with these ENTs, you get these amazing images. This is the epiglottis, actually. So in this case, you could see how the patient is while sitting. Here you can see how the patient is while lying down. So this is the airway, how the airway gets compressed and the epiglottis moves posteriorly. And this is with the sleep appliance while lying down. So amazing images. I just wanted to show you an image. This is how much the airway gets compressed. So if this is how the tonsils are going to be, and those are the adenoids up there, and if the tongue goes back while the kid sleeps, he is going to have those desaturations, right? And those desaturations would end up with the patient clenching, bruxing, as well as, have you heard of ADHD? ADHD is attention deficit hyperactive disorder. So these patients are, most of these patients who have ADHD in the West, they used to be given a lot of Ritalin, and now the whole concept of ADHD medication has changed to Airway. ADHD is actually just another term for sleep apnea or sleep disordered breathing, or even UARS. The first line of treatment now is adenotonsillectomy. So make sure if your kids have ADHD, take them to an ENT and get those lymphoid tissues off. Another case, you can see the generalized attrition, abfraction, Malampati, high arch palate, but this is what I want to show you guys, the lingual tori. So this is a new thing that Dr. Dave Singh, after I attended his course in Korea on the DNA appliance, I've understood how clenching and bruxing could lead to formation of tori. Even if they undergo a surgical process to remove those, they might come up again. Why? Because they're still clenching. So what is the relationship? Most of my patients, if they have, I look for tori. So as an example, I don't have enough time, but I'll just cite you that example. I happened to lecture at an ENT conference, and an ENT came up and said, we don't look into the mouth, we just look at the oral cavity. I mean, we don't even look at the oral cavity. All we do is the Malampati, we don't look at teeth. So, but when I looked into his mouth, he had this huge tori and asked him to do a sleep study. And our sleep study proved that he clenches like crazy. And he knows he clenches, but he never knew he did. And he didn't know those were related. So it's all about observation and diagnosis. So form follows function. So during parafunctional activities, lateral pterygoid stretches the osteogenic perichondrium. So if a muscle is working extra, for example, the lateral pterygoid is basically, the superior head of the lateral pterygoid basically forms the articular disc. So if you continue to clench and grind at such high forces throughout the night, that lateral pterygoid is going to shorten. As it shortens, it pulls the disc forward, and along with the disc, part of the perichondrium and the bone changes shape. You might have heard of beaking of the condyle. The beaking of the condyle is nothing but a simple change in shape of the condyle due to these excessive forces. Same thing with the masseter knot that we were talking about. So the physiology, the most important, you guys need to understand this. So this is the periosteal stretch hypothesis. So for example, heavy forces at short duration, for example, while chewing, that's not going to lead to any changes in periodontium or tooth movement. But during parafunctional activities, both the maxilla and mandible undergo more forces, resulting in bone deformation. Okay, so this bone changes, this addition of bone is actually a protective mechanism so that the bone doesn't fracture during these forces. So both bruxing and the tori are actually saving the human body from deteriorating. First, death and breakage. So it's as simple as that. Open up your mind and think. So this is the brain oxygenation and tooth relationship. The hypercapnia is detected by the aortic and carotid bodies in your on your arteries. To maintain the airway, there is neuromuscular accommodation all over the head and neck area. The bone remodels in response to this change in posture. And if there is a change in dental position, the maximum intercuspation, MIP is interproximation or intercuspate, doesn't matter. That is going to prevent this optimal positioning, and the patient starts clenching and grinding. So let us get to why this happens, these first 2 points. It's going to be the physiology. First year physiology, like I said, first year anatomy, first year physiology, you got to relearn. So flow limitations and oxygen desaturations play havoc with the HPA axis, which is the hypothalamus, pituitary, adrenaline axis, and the trigeminal cardiac reflex. Okay. So just understand this slide, very important slide. There's oxygen desaturation, meaning oxygen going below 97%. Then there is hypoxia, because there's an oxygen desaturation, there's not enough oxygen in the human body. Now this leads to an increase in arterial carbon dioxide, which is a hypercapnia, increase in carbon dioxide. That would lead to a tachycardia, which is increase in beat. Why? To get in more oxygen, right? The heart is beating faster. Tachycardia leads to RMMA stimulation. What is RMMA stimulation? Which is rhythmic masticatory muscle activity. Rhythmic masticatory muscle activity. Basically, your masticatory muscles are increasing their action so that there is more breathing and oxygenation happening to counter the increased hypercapnia. Understand? Now, this stimulation would end up with a bruxing. Oops, there's a W there. I'm sorry for that spelling mistake. So, unfortunately, these RMMA stimulations are not measuring how strongly the muscles are actually clenching. We will get to that later, okay? Just understand this for the time being. Increase in arterial in hypercapnia leads to the activation of the sympathetic nervous system, increase in catecholamine release, which activates the hypothalamic pituitary axis, adrenal axis, okay? And that also leads to the activation of the TCR, which then goes again to tachycardia and bruxism. So another method of bruxism is when there is an increase in catecholamines, there is a hormonal dysfunction, that's an imbalance that's happening. To get rid of these as well, the body responds with bruxism. So these are the 4 ways with which you end up with bruxism. And these are all proven through research papers. Yeah, so that's the next page. So it's mainly Levine and, like I said, Levine and Jill Manor who have brought out most of these research papers. Is all coming from, undoubtedly. So again, everything comes back to, is there proof of this? There is proof. Unfortunately, we are not looking for these. That's the sad part. So now we need to know how many times they are clenching and grinding, right? We need to know how many times, and we need to quantify. Just asking the patient is not enough because the patient doesn't know. They're going to sleep, right? So you need to quantify. So we do a sleep study. All these patients undergo a sleep study. So there are 3 ways of doing a sleep study, okay? One is a polysomnograph, which is done at hospitals. It's the most ultimate way of recording sleep. But if you need to record sleep, the patient has to sleep. And with all those wires on your body, can you even sleep? It's virtually impossible, right? So we normally resort to a home sleep test, okay? With home sleep test, however, you cannot measure the RMMA activity. The home sleep test basically shows you oxygen desaturations. We'll get to that. But what we do right now is use the GemPro Bruxism apnea monitors, okay? So this is what a normal sleep report would look like. They would show you the AHI index and the respiratory index. Oopsie, I'm going beyond time. So the AHI index is the number of apneas plus the number of hypopneas divided by the number of times you sleep. So number of hours you sleep. It should ideally be less than 5. You can see the patient here is almost 21. So that means every hour, 21 times, this guy isn't breathing for almost like 10, 15 minutes. He's not breathing at all, okay? Now, this is what normally ENTs would look at. But because I'm more into pain, this is what I would look at. If you don't have a GemPro study with you, you go by desaturations and flow limitations, okay? Both of these need to be below 5. So what have we learned so far? If there are 89 desaturations, in accordance, there are 89 clenching cycles. If there are 69 flow limitations, there are 69 clenching cycles. Not 100% proof because we are not actually recording the muscle force. So that's the problem with these sleep studies. Even the polysomnograph, the one you do in the hospital, where they do connect to the mentalis and the masticatory muscle, the only way that we would know is as a spike, but that spike can be even just a jaw change position or jaw movement. So you're not actually measuring it. It can be any sort of jaw movement. And that's why we do the GemPro BioBrux reports. So here, with these studies, we can actually relate the oxygen desaturations to the bruxing forces. So here you can see, so we do a baseline clenching report to know how much force is actually being applied. It's almost 370 Newton microvolts. And the patient is clenching at 1,138 microvolts at night because of desaturation. So these would always relate to a desaturation events here. So we always look at number of times, which is 25% more than this. So this guy is almost clenching 300 times. So wow, no wonder those tori formations, right? Okay. So how do we treat our patients? We need a guideline. So this is how I have created a guideline for our patients. If the AHI, because not everyone has a GemPro study, so if the AHI is below 25, all appliances are good enough. If it's 25 to 50, CPAPs. I would not give them oral appliances unless the patient is ready to try, because CPAP is difficult to wear. 50 plus is CPAP, oral surgery, oral appliances with or without surgery. 85 and above, I don't even know how they're alive. Basically, they are like zombies, okay? They need treatment immediately. They could die anytime. So this is what a CPAP does. You would see patients walking around with a box. It's like a a ventilator unit. It pushes oxygen through the nose or some even with the mouth so that the tongue is pushed forward and the airway remains open. Appliances, what it does, it takes the support of the maxilla to keep the jaw forward. Now, there are several appliances out there. There are hundreds of types of appliances out there. Which one do we select? Tongue retaining devices, fixed orthotic appliances, adjustable MADs. MADs are mandible advancement devices, a CPAP Pro, etc. Okay, hundreds of them. Which one do we select? What could be the most important factor? It's all about the bite registration. I don't give a damn, sorry about my language, I don't give a damn about what appliance you're using. It doesn't matter. You can make your own stuff as well, okay? It's all about the bite registration. I've just seen a research paper that shows how bad oral appliances, sleep appliances are for the TMJ and craniofacial pain. Why? Because you are forcing the bite into 70% maximum protrusion. I even heard inside sources from the lab say that some doctors just provide the models, not even a bite, and the lab just creates a position. Oh my God, you'd rather not do anything for that patient. How can everyone have 70% maximum protrusion? Everyone, it's impossible. It has to be muscle specific, custom made for that specific patient. Seriously, are you out of a goddamn mind? It's so irritating to see this happen. So we came up with a TENS protocol, which is the right by TENS protocol, and you also have the more sophisticated K7 protocol. So in short, we use an ALF, it's not just any TENS unit, we use a J5 ultra low frequency unit, or even a bioresearch quarter TENS 2 unit. The difference between this unit and the locally available units are these four causes. First of all, they are ultra low frequency, 2 to 4 hertz, antidromic, they go straight to the nerve instead of to the muscle. So all the muscle supplied by that nerve is being relaxed. They are bilaterally simultaneous. So people say I use two TENS units on both sides. Impossible. You can never do it together. And at precisely 1.44, 1.5 seconds, because that's when the muscles reach the best myofibril length for proper firing. So, and this is the only, these are the only TENS units out there that are patented for all four together. So you would never get any other TENS unit, which is why people say when they say I use a TENS unit, no, if it's not these, you're not doing it right. Simple. So this means that instead of a single muscle getting twitched, all the muscles by the nerve are getting pulsed, and not just the facial, the neck as well. So you have. So we place a TENS electrode in such a point which is in front of the tragus on the mandibular notch. So you have direct access to the facial nerve and the more deeper mandibular nerve. And we also target the spinal accessory. So now we have access to 95% of the muscles of the head and the neck, because we are looking for airway, which is not just a neck thing and a head or a head thing, it's both together. So you need to relax. So it's a group action, all muscles together. So using just the J5, we find out where the jaw has to be with reciprocal forces. It's known as muscle awakening test. So we do a lot of tests to find out where the jaw actually has to be. So this is the basic thing that we do with just a TENS unit. We find the bite, we record the bite, and then we give it to the lab. If you're going a little more, sophisticated, we use a K7 myokinesiography, which is going to be 99% precise. We know at which jaw position exactly how the muscles are.
Excuse me, sir.
So, yep.
So can we just go back to the muscle slide? One of the attendees is telling that you're going a bit fast.
I have to, right? You just gave me 1 hour.
No, you can take more time.
Oh, great. Okay. So okay. What is the question here?
No, they wanted to see the muscle slide. Yes.
Which muscle? This one?
I think this one.
Yeah, okay. So,
And the next slide also.
yeah, so how to position these? These are basically on the junction of the top, the upper third and the middle third triangles of the anterior triangle of, the posterior triangle of the neck. We've learned anterior triangle, posterior triangles. Again, posterior anatomy. So right behind there is where the spinal accessory come out. So the spinal accessory joins hands with the cervical plexus and supplies the traps, the capitis, the rectus posterior, posterior major, minor, all these muscles. So we teach all of this in detail at our conference, at our courses. So because of a time limit duration, I can't teach everything here, but it's all about anatomy. And these are what the facial and the mandibular nerves help us with. So when you're recording the bite, we want to make sure all the muscles are at relaxed position. And when we give a reciprocating force on the arm, we find out where exactly the jaw has to be. I think I'll just go back to none. Okay. Sorry for that. Okay. I think I've got some more time. So people look at midline, not dental. We need to look at frenal midline because dental could be anywhere. It's not the actual thing to go by. You need to go by the frenal midline always. So to get more precise, we use the K7 or the BioPack, anyone, to find out where exactly the jaw has to be. At each point, we know what the muscle readings are. So we would select the point at which the muscles are the most relaxed and most towards the center. So in this case, I would select the 1.1s, which would be number 7. There is a 1.0, which is number 3. Yep, number 3 is there. It is almost in the center. So, yep, and it's forward enough. So I would go for number 3, and that's how we would select. And we can go in live mode, shoot the bite with the patient in that position. That's how precise it is. And then we record the bite, and we provide the sleep appliance. So,
so can you just tell something about recording the bite? Because one of the attendees had asked that, how to record the bite.
How to record the bite? Okay. There are two ways of recording.
How do you prefer to record it, I believe?
Yeah, so there are 2 ways of recording the bite. It's either with using just the TENS unit, or if you can afford the entire K7 muscle reading unit. So with the J5, we are only 70% precise, okay? Like I said, how people normally take the bite for sleep appliances, 70% maximum protrusion. How precise are we there? 0, okay? We're just going for arbitrary positions. There's a 50% chance of it becoming right, okay? But because you're forcing a jaw position to be in where the jaw is not happy with, because the muscles have to reciprocate. Think about wearing an appliance all night to keep the airway open in a forward position where the patient is not happy yet. So you need to relax those muscles, check if the muscles are relaxed enough, and then find out where the jaw position has to be. How exactly to record the jaw, the bite is we virtually mark lines on this bite rim, and we ask the person, once the muscles are relaxed, we ask the person in the myotrajectory to find out where the jaw would elicit the best reciprocal force on your arm. Now this bite is only 70% precise, but it is 70% better, 70% better, absolutely, no doubt, than the 70% maximum protrusion, which is totally arbitrary. So how much do we have to open the jaw to? What about the yaw, pitch and roll? What about the 3D positioning? You're not even bothered about those. So unfortunately, that's what we all have been taught to do, and that's what we are doing. So I'm just trying to tell you that there is something else out there with which you can be a little more precise and more patient specific, a little more customized. You don't have to force the jaw into a specific position.
So, sir, do we generally use a 70% protrusion bite?
No, never.
No,
I never
asking,
use a.
That's the conventional way.
I know. Yeah, so
and,
that's a conventional way, which is not right because
yes,
it cannot be the same
allows us
position.
to record the muscle
happy bite. Exactly.
Okay.
For that person, for that human being, where the muscles are happy, that's where you want to record the bite.
And that should be near to perfect for that person, isn't it, sir?
Exactly. With just the tens unit, that's the right word to use. With just the tens unit, near to perfect. If you have the EMGs and the jaw tracker as well, if you can spend a little more money, it eventually comes to that. So if you don't have a CT, what do you do? If you don't even have an OPG, what do you do, right? So it all depends as to what you can do. People say, you got to buy this equipment, that equipment. No, one second, let me just finish this. People say you got to buy this equipment, that equipment. No, it's not that way. Suppose you're doing a laser course, or suppose you're doing an endo course, or suppose you're doing an implant course. You do have to invest on equipment. It's common sense, right? So here, the first equipment you invest on would be a TENS unit. And if you have the TENS, you can at least start doing the right thing instead of going for arbitrary points. Yeah. Sorry, Unni, please ask. Unni or is it Pravish?
It was Pravish. So,
okay, Pravish,
and any specific agent which you use for recording the bite?
Agent? What do you mean agent?
Like
material?
Material, yeah.
Oh, no. Okay. So, well, I used to use the Blue Moose till it was available in India. But then, like I said, due to the Indian economics. Now, for example, in the US, these patients are charged $7,000 to $10,000. Okay, and that's where I came from. And when I started practicing in India, and I used to charge 3-4 lakhs, I hardly was getting a patient. I'm talking about 2009-10. Over the years, I've learned to be very India specific. So our protocols, we teach how to be a little Indian with these methods. So frankly speaking, I use putty. I use putty, and but right now we are in the process of incorporating the intraoral scanners. So they are amazing because of the shelf life of putty. Now we have better stuff with intraoral scanners. So if you have an intraoral scanner, amazing work. So right now we are doing that. We scan our products to the lab, which is the Right by Judent lab, and we get them immediately in like 2 or 3 days. Earlier it used to take 20 days, now it takes just 3 or 4 days.
So it is like you get the muscle in proper position and you can record it with any conventional method, isn't it, sir?
Yes, exactly. Anything. You can use anything you want. But I would suggest putty more than wax because, or even alu wax. Alu wax is strong enough, but not just simple wax. Let's not be that cheap. But putty would give you an almost good enough reading.
So would you like to continue or take more questions?
So another question has come regarding this.
Okay, so wait, listen. There are just, I think, 4 or 5 more slides. So can I just finish that?
Yes, sir.
Sure. Okay.
We can finish it.
Okay, so these are the appliances that we provide. So these appliances are, again, just temporary. What is the actual problem? Why are these patients actually having a problem, right? Most of them would be a malformed occlusion, malformed bones, constricted arches, a nasal deviation. Another very good example, nasal deviations, deviated nasal septums. These patients would go to an ENT, get those DNS corrected, and they just relapse again. Why are they relapsing? Have you thought about it? It's because we are directly involved. If the arch shape is high, okay, you should remember that the palatal arch is directly connected to the nasal septum. So if the arch is high, the septum is going to get bent. Every time they try to correct it, without the arch getting corrected, it is going to get bent again. Logic, common sense, please. we send our deviated nasal septum patients only, to the ENT only post corrections, post expansion. So we use a lot of appliances for expansion. The DNA, the agar, controlled arch orthodontics, alpha appliances. So these are the DNA appliances. So most of these appliances are not available in India. What I've been trying to do is start these things going in India. The reason, again, most of these appliances are developed in the developed world, and they are patented, so they are very expensive. Now these guys are approaching us because they've seen the market of South Asia. So our lab has now got the rights to form these, to construct, manufacture, fabricate these appliances for a zero less. So what used to cost $2,000 are now just going to cost $200. So and all of these appliances are going to be introduced at our conference. We were supposed to do the conference in March. I'll talk about the conference in a couple of slides. So these are a few of the appliances. The DNA appliance is an 3D expansion appliance, which increases the airway of even adults. Okay? Remember this, of even adults by up to 200, 250%. Believe it or not. The mRNA is an appliance that is worn along with the DNA as a sleep appliance. Again, on the neuromuscular bite. Let's not go for arbitrary bites. Then we have the alpha appliances, which are mainly used in deciduous patients.
Could you just tell us what DNA stands for, mRNA stands for?
DNA is the day-night appliance. And the mRNA is a midnight removable night appliance.
Yeah, that's more sensible, because the DNA and mRNA, which we know, are different.
But actually, the inventor, Dr. Dave Singh, he has shown how these appliances actually. So the functioning of these appliances, again, which we could teach you, this alone took me like 5 days to learn. So can't teach it in a 1 hour session here. So these appliances are patented because they have specific springs on the palatal side of it that engages the rugae, which then changes the DNA pattern. I don't know how much you have heard about changing the DNA patterns of a human being, but these are really possible, and that's how they actually function. So they do actually work with the DNA. So he had two things in mind when he named it the DNA and the mRNA appliance. The ALF, again, the inventor, Dr. Derek Nordstrom, he said both Dave Singh and Derek would be there at our conference, hopefully, if the corona helps us out. So the ALF was mainly used in pedo cases, and they give amazing results. Every time we do ortho, it's non-extraction. So we have Dr. Steve Galela's agar appliances as well. All of these involve non-invasive arch expansion. DNA and the ALF provide 3D expansion. So ALF is more useful in pediatric cases, and the DNA achieves successful expansion in adults. So in the end, it's all about achieving bilaterally isotonic, which means relaxed muscle, centered bite, to help the patient be as comfortable as he can. So you don't give them 70% bites, protrusive bites. You don't give them night guards anymore. You find out what actually the problem could be and be more responsible as a dentist. Stop seeing yourself as just a tooth doctor, right? To remove all the causes to avoid a relapse. Teamwork is the key. You cannot work alone. Impossible. So when I came again to India, my first problem was to find the right team. No chiropractors. There were no physiotherapists who understood how cervical vertebrae. Again, I can't talk about that right now. Not enough time. So my CMD, craniomandibular dysfunction sections are like even longer. So we'll talk about that later maybe. Even the physiotherapist doesn't know that a cervical rotation can change the position of the jaw. We need a neurologist. You need a podiatrist to look for foot length issues when we talked about posture. So we help sports patients. not patients, sports stars. Half the Indian cricket team wears our appliances. You don't know about that. We haven't gone ahead and marketed it. A couple of badminton stars, a few tennis guys, an entire football team. They're all wearing our appliances because they want to function better, because their posture needs to get better. They need to breathe better. They need to sleep better. So this is our company, and these are our centers, the Right Bite Craniofacial Pain Care. We have our head office in Jayanagar, Bangalore. That's our website, tmjindia.com. Our courses are the Right Bite courses. We do it in association with our organization called the ICMO. ICMO is the International College for Craniomandibular Orthopedics. We talk about, it's a organization for neuromuscular dentists who treat craniocervical mandibular disorders, CCMD or CMD, craniofacial pain or CFP, and as a dentist, how to go the next one step forward. So these conferences are held every 2 years. We had our first one, mega success, expected like 100, 150, but we got like 350 people there. We had 10 speakers. So this time we have 15 speakers, all most of them international. It was supposed to be in March. It's now being deferred. I would use the term deferred and not postponed because it's still not sure. 25 to 27 September. Even if these speakers won't be there, if they can't come, if the US is still under lockdown, if other countries under lockdown, we would still have them on Zoom as a webinar, but you can come and enjoy the conference. We'd also have, if they can come in, we'd have workshops on the DNA appliances, on the myomunchia appliances, and on how to read sleep studies. If you want to know more about ICMO, it's an organization for the world. There are only like 800 members. We started our ICMO India section in 2018. And in just 2 years, we are now 53 members. Amazing growth. There are a lot of dentists who are joining us. So if you have any doubts, icmoindia.com. And yep, whew, I need to drink some water. So dhanyawad, gracias, muchas gracias, pasibo, shukran, obrigado, grazie, matse, thank you. Yes, I'm up for doubts.
So some people are asking for the last slide. Can you just keep it?
Let me just have some water, please.
Yes, sir. And I would like to tell all attendees that we do have a YouTube version of the same, which will be uploaded later in the day, and the link will be shared in the group. So any part of the session which you have missed, you can always go to the YouTube and watch it.
Which slide are you talking about?
I think these two slides regarding
the conference.
The conference. The prize one.
What you should do is go to icmoindia.com. Simple. It's all there. It's our website. The online registrations, payment portals, everything are there on ICMO India with the new dates and everything. So we will do it. Maybe not in September. If it's again deferred, maybe October, November. We will be doing it, but because of the Corona thing, I've not been. So because of my hectic travel schedule, I'm hardly at home. So it's the first time in like 8 to 10 years. Normally I'm at home for like 2 or 3 days. It's the first time that I've been at home for like 40 days. So I'm really enjoying this. Thank you, Corona. I should not be saying that, but the beard is a new thing on the personal front. Yeah, any more doubts, please? I'm sorry.
Yes, there are lots of, I think Dr. Unni will be asking it.
Yeah.
Okay, Unni, please.
So the first question is, have you ever got a patient who has night bruxism, but the sleep study when done gives normal result? What would be the etiological diagnosis and the treatment?
Good question. Absolutely good question. So it depends on the parameters you're looking for. If you are looking for just the AHI, so how do you look for bruxism, right? You need to be looking at the desaturation. So if you're using a polysomnograph, which are PSGs, the sleep study level 1, level 2, and everything, you would see RMMA activities. If they are more than 10 or 15, they are bruxing. Again, you're only 50% sure. If you're looking at PS at level 3 studies, like the one I showed you with ResMed, you're looking at desaturations and flow limitations. They should be less than 15. If they're above, yes, they may be bruxing. So again, you're only 30 to 40% sure. Ideally, I use the GemPro because I want to be sure. But the GemPro is something that I added to my paraphernalia only like last year. So prior to that, 10 years I've been working with just the PSC studies, and they have proved to be very vital to me. So because it's at least better than not doing anything, right? That's how I'm looking at it. I hope that has answered the question.
Okay, sir. The next question is, do you use T-scan or do you believe in timed disocclusion therapy?
Whoa. Okay. So it's not in the epilogue of this specific
Webinar.
Webinar. I'm sorry, I wasn't getting the word because I was just taken off guard here. There is a misconception about neuromuscular dentistry out there. T-scan is only a diagnostic tool. Okay, people think, I don't know whether it was a marketing ploy or what, but T-scan is not a treatment tool. You need to use different other tools to incorporate T-scan as a treatment commodity with your disclusion time reduction. But then that has got nothing to do with sleep. So when a patient comes, typically a patient comes to me with pain, okay? CFP, craniofacial pain. And with all the diagnostic protocols that we follow, I suppose I do diagnose a patient as having CMD, craniomandibular disorders, okay? Craniocervicomandibular disorders. I relax the muscles, I check the myocentric, I find out where the jaw has to be, I give them an orthotic, and I need to correct those orthotics now. I've seen people use those locally available Vijay, or even with my name, Rajesh articulation papers, which are like 140, 150 microns. That's not fair, okay? Our occlusion has the proprioception levels of up to 8 to 10 microns. The thickness of a human hair, oops, I don't have it. So if you're going to be checking those proprioception levels with articulating paper, that's unfair to the patient. You're not checking the right thing. That's when, if you cannot afford a T-scan, well, you could do even good with a Bosch articulating paper, 20 microns, they are there. If you want to go one step better, so it's all about how much better do you want to do for your patients. If you want to go one step better, use the T-scan. I mean, there is also another equipment known as the occlusion. So it's not just the T-scan. So the occlusions is actually a digital version of the articulating paper. Okay, the T-scan is one step beyond because it actually records how much time the jaw takes to disclude from CO to disclusion, right? Incentric and canine disclusion or anterior disclusion. It should be less than 0.4 seconds. So that is done by the T-scan, and hence it is important in treating CMD. But the T-scan, just as it is only a diagnostic tool. So when a patient walks, I mean, if I look at 100 patients, maybe I help maybe 10 to 15% of my patients with DTR, because deep bite patients, in my protocol, you can't reduce any more teeth for a patient with deep bite. They need to open up. So you do addition NMD and you give them orthotics. On the other hand, I use the T-scan on every patient of mine with an orthotic because I need to check for micro occlusion. So you need to be very sure as to how you want your practice to be. You'd better consult with a senior doctor. I'm ready to help you guys, as to how you want to change your practice, what sort of equipment what sort of budgets you have. So you can chip and choose what you want. I hope that answers your question. But it's got nothing, absolutely nothing to do with your sleep apnea.
Okay.
Okay.
Okay, sir. Okay. So next.
Is it clear for you, Pravesh? Because I'm not sure if it's clear for the person who asked the question.
Yes, sir.
Okay, great, cool.
Great. Now, so the next question is, one of our patients is wearing EMA. He's sleeping well, more energy, but wakes up with cheek or jaw pain, even after using yellow or white bands. Band size initially, band size 90. Initially, it was fine, but this pain started after 2 months of wearing. What is the cause or what to do?
Sir, could you also...
That's the bite registration.
Sir, could you also please enlighten us about this appliance, EMA, and regarding the...
Yeah, so like I said, there are several appliances out there. I'm not even... So EMA is an elastomeric mandibular appliance. It's one of the mandibular advancement MAD appliances that are available out there. The appliance doesn't matter. You have to understand this. Now, that patient might be waking up better. That patient might be having a better airway. So he's oxygenating better during night. His body is repairing better. The cells are repairing better because there's more oxygen. So what's the best medicine for the human being, for the human body? Oxygen. The purest form of oxygen, right? And which is why the Buteyko method, the art of living, pranayama, any meditation, any breathing technique improves the human mind and body because it is all about getting in oxygen. And the best oxygen, and if you get more of this at night when you sleep, that's when all the body cells are repairing. If the jaw is, if the EMA appliance or the Silensor or the Somnomed or the TAP or any of those appliances, it doesn't matter. It seriously doesn't matter. I used to give appliances because my patients can't afford, a 20, 30,000 or 40,000 rupee appliance or a 7-8 lakh appliance. So I can't. So I used to give them just customized acrylic appliances, but in the muscle bite. So even if you give an EMA appliance, if that appliance wasn't a muscle-centric bite, more than, so that, I would actually ask a reverse question. Was it on a 70% protrusion with a George gauge? How did you decide what should be the vertical? How did you decide whether there is no yaw? I mean, whether there's no yaw or roll in the mandibular position when you did do the recording? How did you decide all of this? Did you measure the muscles? Are those muscles happy? What about the neck muscles? Are they relaxed? No. That's why you end up. So I used to have an office. I used to work in Cochin, and there is this, because of my lack of time, I had to stop working there. So there is a lab in the area, and we used to get a lot of patients with CMD because of these appliances not being given in the right bite. Imagine, believe it or not. So, which is why I said that study that came out like a month ago, and my friend wrote that study, Dr. Supriya or Sripriya. So she, when she mentioned that mandibular appliances create CMD, it's because of this. You're not recording it at the right muscle bite. It has to be very important. Everyone has to understand this. We as dentists should not be putting down ourselves even more. We need to understand how important muscles are in the concept of occlusion and jaw position, and keep muscles up there. Is that clear? It's all about the bite.
Okay.
Yeah.
Okay. Yeah. Muscle-centric bite.
Yeah. Muscle-centric bite. Bam.
Okay, sir. The next question is, what is your take on the correlation of OSA with chronic fatigue syndrome and other MSK disorders? Harneet Singh, Dr. Harneet Singh.
Yeah, so if there is sleep apnea, like I said, it's not all sleep apnea patients have bruxism, or all sleep apnea high AHI cases, not all of them have desaturations. Okay, so it all depends on the sleep study. So which is why we need to quantify. We need to be sure. So we make sure that we do the sleep study and we find out whether the patient is clenching or not. So most of these morning headache cases, they end up as migraines because none of the doctors understand why those. So for example, when a patient has a headache, constant headaches in the morning when they wake up, they go to a doctor and an ENT or a neurologist. They try different drugs. One drug doesn't work. The next drug doesn't work because they're not getting to the cause of the problem, which is the clenching. All they would give are tabs. And once these tabs don't work, okay, you have migraine. So that's what happens with wrong diagnosis, faulty diagnosis. Again, the term that was used, musculoskeletal pain dysfunction. There is myofascial pain dysfunction. There is, myalgias. There is, so there are so many terms that are myositis. There are so many terms that have been given because a doctor is not able to actually diagnose. My diagnosis would be the whole thing. It would be CFP, craniofacial pain. It's part of the dentist's job to take care of finding the diagnosis, finding what is actually causing the problem. More often than not, it is sleep apnea related bruxism, for which you need to follow these protocols that I did mention right now.
Okay, sir.
Yeah.
So do you think that all patients with snoring needs to be assessed for airway obstruction? It has to be airway obstruction.
Absolutely. Good question. In my experience, when patients come to me and you ask them, do you snore? Most of them like, a little, hardly. Well, it doesn't matter. Snoring is caused because of a posterior placement of the tongue. So you saw in that video how the tongue goes back. So when the tongue goes back, it hits the uvula, the small tongue that hangs below. So with patients with Malampati 3 or 4, where you can't see the uvula at all, it is understandable that when you go to sleep, both gravity and the jaw position is going to push the jaw back and the tongue is going to hit the uvula. So sometimes so it's the tongue hitting the uvula that actually creates a snoring sound.
Yeah.
So it could be as light as, or it could be heard across buildings, and so that's also, so both are snoring. It doesn't mean the former guys are not snoring. They are snoring. The former section, they are also snoring. No matter what, is that snoring habitual or is it pathological? That's what needs to be ascertained. And only with a sleep study, along with other diagnostic protocols that we talked about today, can you decide whether that snoring is dangerous or not. So if you do a sleep study and you find the AHS are high, bam, that's pathological. If it's not, it's just a habitual snoring. If you are the spouse, then and you're getting disturbed, well, give them a sleep appliance, but it's not going to hurt that person health-wise. But if that person is pathologic with that snoring, then it's going to hurt them health-wise. There's a study that shows 20-25 years of snoring is going to will end up with cardiac problems. So again, 80% of all that snoring could be pathologic. So we need to do a sleep study to ascertain whether it's habitual or pathologic. Another example, so I have a drink once in a while. When I drink more than normal, more than often, more than the normal amount, I snore like crazy. So I travel with the sleep appliance because when I'm tired or when I go beyond with drinks, I wear the appliance because I need to be functioning the next day. I need to, that question also involved awareness. If your sleep is getting broken and you're not having enough REM sleep, 25% REM sleep, that sleep is carried over to the next day. So it affects your functioning, your quality. You're not going to be attentive enough. So I want to be functioning at my peak. So I wear a sleep appliance when I'm traveling and when I'm drinking. So cheers. Next.
Right, sir. So whether it is snoring or to know the etiology of bruxism, you need sleep study.
Yeah,
That is
absolutely.
how we can diagnose all that.
Yeah.
Right, sir. Now, the next question is, after you take a myocentric bite, how long should the patient wear the appliance? And would you be giving the same bite to your restorations?
Oh, good point. No, absolutely not. The sleep appliance is only for the sleep. So there's a group of doctors who are against dentists. So again, okay, let me get to the economics and what's happening with the sleep medicine politics in India. Doctors are scared. Right now, sleep medicine is covered by neurologists, ENTs, pulmonologists, and they are into CPAP units and surgical procedures. When most of these patients, all they need is a sleep appliance. Actually, when you do a sleep study, the companies ResMed and Philips, when they do that sleep study for you, so before I got my GemPro, we used to outsource them to these companies. If the patient has an AHI of 15, that comes with mild and they don't need to do anything. Absolutely not. The reason why they write mild is because their way of treatment, which is surgery and CPAP, they aren't as functional with smaller AHI values. So that's where we dentists come into play. And we need to be providing these sleep appliances only during night. So there are a group of people that say these sleep appliances change the position of the jaw permanently. Absolutely not. Because you wear it only at night, and that too at the muscle-centric bite, not in a forced bite. If you wear it in a forced bite, yes, there is a chance of changing the jaw position permanently. But if it's in a muscle-centric bite, it's not going to change because you're going to be chewing. Your jaw is not moving at night. It is to stop the movement of the jaw that you're wearing the muscle-centric sleep appliance. In the daytime, when you remove, you're going to be chewing, you're going to be talking, you're going to be swallowing when it goes into maximum MIP. The only time it goes into MIP. So when all that happens, the jaw position is going to be regained again in max 3 to 4 minutes. Some doctors provide with jigs. I don't even do that. By the time you finish brushing, it's fine because ours are muscle-centric bites. So we don't need to be bothered about that.
Okay, right. So you told us about the DNA appliance in adult patients and how it can affect the arch expansion and all that. How do you stabilize that expanded arch left there?
Oh, ever since I've got into neuromuscular dentistry, I've stopped giving retention appliances. Pravish, I think we are getting into the pain side of it, but I don't mind talking. I'm free. So, why has it become a part of orthodontic protocol? Why has the fixed retention appliances become a part and parcel of orthodontic protocol? Why? Because prior to treatment, we aren't taking care of the airway. We are not looking at how the airway is. We are not looking at the other causes. We are not looking at the posture. Are you looking for a short foot? Why should a dentist be looking for a short foot, right? But these are the small things that, it hardly takes 2 minutes of your time. That's what we do. We check every patient for all of this. And ever since I've been doing that, I have not delivered even one retention appliance to any of our orthodontic patients. You don't have to. You don't have to.
Even after you're giving the DNA appliance in an adult patient.
Exactly. Even DNA. So what's happening? What is the problem actually? It's the constricted arch. There's no tongue. So the tongue, no one understands the value of the tongue as a muscle there. The tongue is a huge muscle. It's so strong. It's so powerful that it extends forces on the teeth that are beyond our control. So you need to make space for it. You need to get mandibular freedom. You need to expand the jaw. I'm not saying do all cases, not especially. Now you could you could go by anthropological studies. Okay, so North Indian facial structure is different from South Indian. We Dravidians have a more bimax structure. So yes, you could maybe do an extraction orthodontic case, but always end it with a expansion. not finish extraction and give a fixed retention and leave the patient. And why are we talking about just orthodontics? Look at prosthodontics. I've seen a lot of cases where, you know, an across the arch bridge has been given. There's going to be so much cranial strain. For some of the patients, we just had to cut across through the center and pain is off by at least 50–60%. So these are small things that we need to be aware of when we're treating our patients.
So regarding the DNA appliance, is it even for adults or only for pediatric?
It's for adults also.
It's not just adults. It depends on the case. It depends on the payment capacity because it's a little more expensive than the ALF. The DNA is faster. The ALF is slower. So
one orthodontist had asked that whether the arch expansion, how good is it, arch width which you get out of DNA?
It's amazing. Okay, so if you go to the website of Vivos, it's actually Vivos website, you will get a lot of research material that shows you about the DNA appliance and the mRNA and ALF and everything.
And so, how long does it take?
The DNA appliance in adults normally a year and a half, but I've seen results in like 6 months, 8 months. The remaining time is for kind of a stabilizing time to hold it in place. And once the bone osteogenic activity has been completed, you can remove them. They don't need any other appliance after that. Finished. Simple.
Okay. Right.
And the ALF in kids would take a year and a half easily.
Yes. So for twin block therapy, do they, for children, do they also need to have the muscle activity recorded?
Yes, exactly. So I have this young, very energetic orthodontist who's in my team in Trivandrum at Kim's Hospital. I have a attachment there as well. So he was telling me that I've been doing a lot of twin blocks. So, but I'm not sure where the bite is. There you go. Why don't you do those twin blocks in the myocentric bite, in the muscle specified bite? You get better results. You know where exactly the jaw has to be. You're anticipating the jaw position. You know that this kid has to grow to this level, right? You don't need to be going to arbitrary points. So, amazing question. Yes, it has, if possible, yes, frankles, everything. Bring it to, and now with, I don't know if you've heard of Insignia. It's an Onco product, Damon. They are actually customized Damon brackets. Dr. Gurkir, a good friend of mine, he lectures a lot about them. So I think
he's one of our attendees, sir. Yes, sir. He's one of our attendees here.
Oh, Gurkir this year. Hi, Gurkir. So you should actually shoot those questions about Insignia straight to him. He would explain it better. Anything else?
Right. Then, how will you diagnose bruxism in patients with an abrasion, in normal dental clinic setup?
Yeah. Normal. So again, it's so every dental clinic is normal. It's up to the doctor to decide whether you need to go to the next step or not. So, like I showed my first slide, where you see show me the money pouring in, you know. So when the money is pouring in, basically when you see a patient with totally arthritic teeth, you're like, wow, in comes a 28-unit ceramic case. Amazing, right? So you see abrasions there. What would you do? You would give crowns. You would fill those scooped out enamel teeth. You would fill those abfractions. But you forget to ask yourself, why did they form in the first place? So most of those attritions and abfractions are caused due to... So the next question, instead of telling the patient, oh, these we can fill, instead of telling that, the next question is, do you snore? Or how do you sleep? So the patient is going to give you an odd look, surely, because he's like, why is the dentist asking me this question, right? Well, that's what a dentist should be asking. The dentist should be asking that question, and we need to change that outlook of patients towards us. So ask the question, do you snore? Tell them the problems with sleep apnea, tell him that you can die. Scare him. Okay? Yeah, I can take care of the tooth. But if you do it with the sleep appliance, better. If not, this can wear away soon again. That's all you need to be telling the patient. That it's going to relapse. That problem is going to, it's going to wear away again if you do not wear a sleep appliance. So, is that clear?
Yes, sir. Okay.
Okay.
Pravish, any questions from your side?
Wow, there's a lot of questions. How much time were we on?
Sir,
There's a question on T-scan. How much does it cost?
Okay, so so there are two occlusal, checking appliances out there.
They had asked like cost, uses, and significance of T-scan.
Ha! So this is the problem, right? Why is everyone so T-scan centric? Anyway, I have a T-scan at all my centers, but I also have an occlusion. It's because of the sheer number of patients, so we need both working in tandem. I use a T-scan only for my DTR patients because you can connect it with the bio-EMG and find out the muscle along to do my DTR. The T-scan, there are two versions available. The older version is, I think, for 6.5, and the newer one is for 8.5. The occlusions is available at 1.5. So it all depends as to what your outlook is. We do our courses once and twice a year. We explain to the patient, to our participants, when to use which, what protocols need to be followed, the right bite protocol, addition NMD, reduction NMD, DTR, sleep, posture, sports. So all this is taught about in our 5-day course that leads to your fellowship program. So maybe for further information, why don't you do one thing? If you have any more doubts with pricing, I don't deem it right as a speaker to be talking about the economics. I think you should be talking to our executive director of ICMO India, Dr. Aishwarya. She could help you with all of that because we have special prices for all these companies have tagged along with us for special prices for ICMO India members. So maybe you could contact her and get further information. ICMOindia.com, please. Our email ID is there. Please shoot your doubts there.
Right.
I'm just being very ethical.
I think that's all from my side. Any more from yours, Uni?
Nope. How was body posture related to sleep apnea?
Yes. Yeah, good question. So when you're looking at sleep apnea, most of these sleep apnea patients would have forward head posture. Okay. The reason is most of the sleep apnea patients have a small airway. So the body is virtually trying to repair itself. It's a physiological response by the body telling the head to move a little forward so that the airway opens up. So when the head moves forward, there is going to be some change in the yaw, pitch, and roll of your jaw. Okay? And if that change happens, there's going to be a change in your cervical vertebral position as well. And that would lead to change in your body posture, your shoulder position, your hip position, all to compensate. So we have patients with leg pain, with feet, with their pain in the toe caused due to TMD. So it's all about your diagnosis and how you get to that.
Sir, any book which you would like to recommend to read about?
Yeah, there's no specific. So it's again, I don't want to be sounding so damning about it, but our dependence on textbooks is what the problem is. Neuromuscular dentistry is more about new research. So if you can get your hands on new research papers, again, ICMO India has all of them. But there is a textbook by Jankelson. So it's known as Jankelsen's textbook of neuromuscular dentistry. There is Robert Kirstein's book on occlusion for T-scan and DTR. There is Robert Kirsten, and there's Robert Jankelsen's textbook on airway. there are a few textbooks, I mean, books out there. I wouldn't call them textbooks. There are books out there. But it's more about being up to date with research papers.
Okay.
Again, if you have, I will message all these students. The groups, the WhatsApp groups are available. I'll be messaging all of these details so that you can check them out online.
Yes. So Gurkirat sir is online. I don't know if he can hear us. If he would like.
Hey, Gurpreet.
Yes.
Hi, Ravindran. Great to see you and very informative talk.
Thank you. How are you? Long
All
time.
good. Yeah, we are all stuck in our homes, and I sincerely hope that everybody stays home and stays safe.
Yeah, but thanks to these webinar sessions, everyone's kind of busy. So
Yes.
thank you. Thanks to technology, right?
Yep. Great seeing you.
You're in Delhi, Gurpreet, or somewhere else?
Very much in Delhi. Very much in Delhi.
Okay. I know Delhi is supposed to be my next stop, but I don't know when that's happening.
Yeah, I know. Just whenever you are in town, just give me a buzz.
Yeah. Of course, surely, no doubt. Cheers till then.
Cheers, boy.
Thank you.
Right, sir. That's about it, sir. Next, we'll move on to the next phase. There will be a.
Okay. Cool. Thank you, IDM Malabar. IDM Malabar. Thank you for this opportunity to spread the word of neuromuscular dentistry. I'd like to thank your president, Dr. Shaju. Is he here now?
Yes, sir.
Yes,
he's
he's here. He wants to.
Hi, Dr. Shaju.
Yeah.
Thank you very much, Dr.
He's
Najee,
online.
Secretary, and your CD convener, and Dr. Pravish. And Dr.
CD convener is Unikrishnan. I am the
Pravish, the guy who organized all of this. Thank you very much, and I hope I was of help to you guys. And keep in touch. I am very, active on all social media, so you can shoot me doubts and questions whenever you have. Thank you again. Bye.
Shaju sir would like to say a few words.
Okay. Hi, Rajesh. I came a little bit late. That's why I couldn't talk to you in the beginning.
No, that's okay. No problem. As long as you join.
Okay. I think this is the first CD program which is entirely different from other routine subjects.
Well, as I look at it has to be different. I always believe in being different.
And my special appreciation to Dr. Rajesh for, of course, sharing such a different knowledge to us, and of course, this for presentation. And my sincere thanks to Dr. Unni, Dr. Pradeep, for the efforts in organizing the session. And finally, on behalf of IDM Malabar, I sincerely thank all the participants, and thank you all. Thank you. See you and enjoy. Bye-bye. See you all.
See you all. Thank you.
There was sir, there was Dr. Sedu sir who said hi in the beginning. I'm not sure whether he is online now.
Oh, Sedu, he's my super senior from college. Sedu Sivshankar.
I'm not sure whether he's available now.
Yeah, he is here.
He is here. Yes.
Hi, Dr. Sedu. Hi. Sedu had helped organize a lecture by me, I think 2 or 3 years ago in Calicut. I remember doing that presentation.
2 years, 3 years back.
2 or 3 years back at Ravi's. So thank you. Thanks, Sedu, for that opportunity. So listen, you know what? I see, Pravish, I see a lot of questions on the chat box and the question answer section.
That's been dealt already, I believe.
No. There are so many very valid questions. What I want you to do is, number these questions, and I will the ones that I have not answered, I'll just number them and answer again. I'd love to answer them, so I just want to answer everyone's questions.
Yeah, there are a few.
I could do that on the group. So just copy paste them onto the WhatsApp group, and I'll just
Yeah, I've done that, sir. 9
Oh,
of
so
them
I'll do
are
it.
unanswered. I've copied it.
Okay. Okay. Great. Cool.
Great.
Thank you.
So
Okay,
all the
sir. Thank you.
attendees,
I guess.
this will
Thank
be
you.
available on the YouTube, and there's an e-certificate for all the attendees. I've given the instructions in our group, and the YouTube link also will be shared in the group. Thank you.
Thank you, Rajesh, sir. Thank you.
Yep. My
Thank you.
pleasure.
Thank you. Thank you. See you all. Bye bye.
Bye, sir. Bye.
Bye, sir.